So thank you and welcome everyone to this International CML Foundation's key discussion on CML Latin America. I'm Arlene, I'll be your moderator today. And before I introduce our speakers, I'll just take a moment to tell newcomers a little bit about the foundation, what we do and how we do it. And my slides have decided not to share, not to move. We just practiced this a second ago. Why don't I stop sharing and then perhaps start again? Okay, from the beginning. There we go. So we are a physician and researcher-based organization with two key priorities, both of those working towards improved outcomes for CML patients worldwide. Firstly, we're raising the bar of CML management through CML education, and that includes meetings like this. Over the past 15 years, the Foundation has been working via preceptorships, in-person meetings, and online with our case discussion forum and our knowledge center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of our work is harnessing the power of global research. Our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance, we did lots of work around CML and COVID. We have a hepatitis B survey, which was rolled out recently. And if you missed that hepatitis B survey and you'd like to contribute, please get in touch with me as soon as possible. We're also looking at CML in pregnancy in low and middle income countries, pediatric treatment of CML in low and middle income countries, and lots more to come. That's a brief overview of the International CML Foundation, who we are and what we do. Please reach out to me if you have any questions or want to know more about our programs. Okay, so our discussion today covers two topics: anticipating and managing acute TKI toxicity and adverse events, and choosing third-line therapy. Before introducing our speakers, I'll just cover off on some logistics and housekeeping. We want these meetings to be inclusive and interactive. You'll all have the opportunity to ask questions and make comments, but for everyone's comfort, please leave your microphone switched off until you actually want to be heard. By contrast, it's really nice for our speakers and for me as a moderator to feel that we have an actual audience there, human beings to talk to. So you're welcome to leave your cameras on. You can submit your questions via the chat function or raise your virtual hand. If you have any logistic questions or if you need assistance during the meeting, please message our host, Nicola Evans, via the chat. Interpretations issues, please message our interpreter, Sharona. Okay, so our first topic for today is anticipating and managing acute TKI toxicity and adverse events. And I'm delighted to introduce our regional expert for this topic, Dr. Ana Inés Prado from Uruguay. Ana Inés has been the leader of the CML clinic at Maciel Hospital since 2008. She's a co-founder of the Uruguayan Group for Chronic MPNs. She's active in the Latin American CML group, and she's part of the steering committee for the ICMLF's regional Latin American regional discussion group. In a first for these meetings, Ana Inés will present in Spanish. It's a pleasure to share the floor with you. Bienvenido, Ana Inés. Our international expert for this topic is a giant in CML field, Professor Mike Mauro from New York City in the USA. Mike is the leader of the NPN program at the Memorial Sloan Kettering Cancer Center, a professor at Weill Cornell Medicine, director of the ICMLF, and an all-round great friend of our organization. Welcome, Mike. It's such a privilege to have you here again.
Just for the record, I'm only 5'6", maybe, so I'm not a giant by any stretch.
So my slides are down, and I will hand over to Ana Inés to get her slides up. And as she's doing that, I'll let the audience know that Ana Inés will spend 10 minutes presenting her first case. Mike will comment on it, and then we'll open up to the other experts and you, the audience, for questions and comments. Ana Inés will then present a second case. Mike will comment again, then we'll open up. Also, we'll also properly introduce our other experts before their session. Let me tell you that Professor Tim Hughes and Dr. Virginia Abello-Polo are already present, and I'm sure they will let their presence be known for this topic too. Okay, Ana Inés, you look as if you are ready to go.
Good evening. First of all, I'd like to thank the International CML Foundation through Nicola Evans and Arlene Harris for this possibility to participate and do so in Spanish. I will be talking about how to anticipate and manage acute toxicity with TKIs and adverse events as well. The first case is of a male 59-year-old patient. At diagnosis, he was 59. He had a medical history of ischemic heart disease and a reduction in the LVEF at 46%, and he was a smoker. This patient in October 2022 underwent a diagnosis and was diagnosed with CML at the chronic phase and high risk SoCal score and intermediate risk UTOS ELTS. At the beginning, the patient was undergoing diagnostic tests and diagnosis was being confirmed. He had over 200,000 white blood cells, moderate anemia, and he got hydroxyurea initially. Once the disease was confirmed and imatinib was made available, and so the regulator allowed and authorized imatinib as first-line treatment. He had 10,200 white blood cells, 5,100 neutrophils, and moderate anemia and platelets at 140,000, and he was started on imatinib at 400 milligrams a day. He came under control. There was a drop in levels initially, but at day 15, he went in for a visit, for a follow-up, and what we saw was neutropenia. And according to the guidelines, it's grade 3 at 800 polymorphonuclears with moderate anemia and severely low platelets. So initially, the question was because this was due to the BM clearance. Since the normal hematopoiesis had not been recovered, and what was ruled out was the deficiency of metabolites. The patient was kept on weekly follow-ups, and at day 37, the CBC after 2 weeks off the medication had not improved, so a decision was made to check his bone marrow. We ruled out an evolution to blastic crisis, and what we saw in the bone marrow was hypercellularity, atypical megakaryocytes, and erythroid hyperplasia. And in the granular series, there was basically immature lineage predominance with 2% of myeloid blasts and grade 1 reticulin fibrosis. So we made a decision to change the medication. His neutropenia had improved, and his whole situation was pretty stable. On day 52, he was put back on imatinib, and due to the degree of toxicity, we decided to put him on 300 milligrams a day, a lower dose. The patient is followed up on a weekly basis. His hematological CBC was pretty stable, so we tried to bringing up to 400 milligrams a day, also with support with filgrastim. His neutrophils went back down to 700 with severe anemia that required a transfusion of red blood cells, and his plaquetopenia was also severe. We checked his bone marrow. We ruled out those blasts, and we checked all 3 lines. He was the treatment was insufficient, and we had to withdraw it several times. But after cytogenetic checkup, he was doing. He wasn't doing well, so a new inhibitor was considered. We did additional tests through by ASO-PCR for faster results, and do a analysis by Sanger sequencing. At day 100, we received the results of the T315, which was negative. The patient was doing much better, hematologically speaking, and we requested dasatinib. So there were 10 days while we waited for the medication, and his CBC was basically normal by then, and we started him on dasatinib at 50 milligrams daily to assess tolerance. We continued to follow up, and the patient had good tolerance for dasatinib, and his CBC improved quite significantly. By day 125, we decided to bring him up to 100 milligrams a day, and that's where we got the results of the Sanger sequencing that identified no mutations. The patient continued to come in on a regular basis, and 3 months into dasatinib, he obtained complete cytogenetic response, and molecular response was measured by international scale of 2 logarithms, and he was still anemic, but it was mild anemia and without intolerance or any complications. At 9 months, he attained full molecular response or deep molecular response, and his CBC was normal. So, in order to take a deeper dive into this situation involving toxicity, hematological toxicities of TKIs, the question was whether, in your experience, whether you use granulocyte growth factors in these cases, also whether you consider the use of erythropoietin or trombopag, and how long you wait to check the bone marrow, and in which cases you consider switching TKIs. And what we're also wondering is whether if there's a recurring hematologic toxicity with the second TKI, what would be the best approach? As we all know, hematological toxicity is a class toxicity that presents with all TKIs, and which was already present in the studies that led to the approval of these drugs. They happen frequently, and it is quite frequent for them to be severe with grade 3 and 4 toxicity levels. We also brought in this meta-analysis, which we felt was very interesting because it assesses the presence of hematologic toxicity linked to the stage of the disease as well. And chronic stage patients between 25 and 30% will present with some type of toxicity, and in the accelerated phase, 2/3 will, and especially there will be anemia during the blastic phase. So now I'd like to open the floor for comments and questions, hear from you, and see what Professor Mauro thinks. Thank you.
So Professor Mauro, welcome. Ana Inés, could you go back 2 slides to the slide that had your questions there? And Mike will get you to give us your thoughts.
Sure.
Ana Inés, could you go back 2 slides, please?
Yes.
Well, I can start while we're waiting to get the slides ready. So that, can everyone hear me okay?
Yes, perfectly.
Yes.
Good. So, this is a great case, Dr. Prado. I'm glad you brought it forward, and such a thorough look at this. And if we walk through it, I think we go all the way back to the beginning. I think there are certain issues that we all have to manage. And, some of the, but just for off the record, some of the other toxicities are a bit easier to talk about. Pancreas enzyme elevation, liver enzyme elevation, gastrointestinal toxicity, dermatologic toxicity. This is the real clinical dilemma when someone has myelosuppression and we're aiming for good response and we're really stuck. So if we go all the way back to the beginning, we note this patient had hydroxyurea for a fairly long period of time before TKI treatment, and that often has a bit of a dampening effect on the bone marrow. I mean, it's often necessary if a patient has more extreme blood count elevations, but if we go all the way back to the phase 1 imatinib study, patients actually entered with high white count over 100 in the original study. So just a point is we don't need to use cytoreduction in a CML patient if we do have access to a TKI, but that doesn't always happen. Sometimes a diagnostic workup needs to take place, and we don't want the patient in danger or to have what can be dangerous or sometimes morbid complications from hyperleukocytosis and other issues. Then we look at the patient, and he had, as we judged, somewhat higher risk or intermediate to higher risk disease. And at the time he started TKIs, the blood counts were not robust. They were probably already, again, affected. And, Ana showed us the effect of all the TKIs and how they impact myelopoiesis and what the rates of myelosuppression. It was interesting. If you look at chronic accelerated and blastic phase, it's not terribly different. It, of course, is heavier when you have more advanced disease and a more involved bone marrow. But I think what we're really dealing with is a good problem, and that myelosuppression is clearing the marrow, and you're essentially looking for catch-up of the normal hematopoietic elements. However, that doesn't always happen easily. Also, if you look at Anna's look at the comparison in TKIs, imatinib is, perhaps not the lightest when it comes to myelosuppression. It may be because, like the the active site inhibitors, it has a potential for other targets, and really in these patients we may the rate of decline of the B-cerebral clone and the rate of recovery of the normal hematopoietic clone are in competition, and imatinib may be a very good drug, but it may not be the fastest. If we fast forward to our newest data with this drug asciminib, and even just look at the second generation inhibitors, myelosuppression may be a little bit less because the efficiency of decreasing the B-cerebral clone may be better. And then I think touching on one of the questions, how long do we wait to check the marrow? I think that this case really highlights the importance of asking that question, because you really don't have an idea in a patient like this if they may have a blastic clone or transformed disease even at an early time point, or they have myelosuppression. It's very reassuring to have the bone marrow Dr. Prado showed us, which showed a hypocellular marrow and a treatment effect, although we are then challenged by not having good response. So of course, I think the ending is very nice here. The patient was switched to a second generation TKI, and with the right strategic approach, dosing lower first, then dose escalation, and then touching on these questions about growth factors. When can we use them, and how do we view them? I think very early on we asked a question about granulocyte stimulating factor, and I do not believe we have concerns that accelerates the disease or leads to transforming potential. I think it's CML, biologically is probably growth factor independent in many ways. That's really how it generates. So using granulocyte growth factors, I think, is reasonable, particularly when you have this type of situation of maybe limited response and persistent neutropenia. I think there's a little bit less clear data on the ESAs or platelet stimulating agents. They've both been studied. I think there was a little bit of concern with some studies with erythropoietins and the limited effects of eltrombopag or other TPO agonists, but I think they're also reasonable. So I think I'm going to let other people speak a bit, and I think we might have a segue to our next group of experts. We talk about hematologic toxicity recurring, and when do we consider yet another drug?
So Tim and Virginia, would you like to give us your thoughts on this?
Yeah.
Tim, you're on silent.
Really, really interesting case. A number of points that Mike's really covered nicely as well. I think the hydroxyurea is a really important issue. I think we do like to use it while we're making the critical decision about which TKI to go ahead with, but I think we often do overdo it and try and get down to normal counts. We don't need to get down to normal counts. I think getting down below 100 white cell count is probably a good thing from a safety point of view. But if you really try and push it aggressively, you can often end up with this situation of early cytopenia. So I think we need to be, we tend to stop the hydria and give them a bit of a break before we start the TKI if we possibly can, but obviously use the TKI as soon as possible. Interesting dilemma in this patient, high SoCal score, or was it high ELTS, a high risk score, but also significant cardiovascular problems as well. So I think imatinib was a good choice. I guess the only other thing would be to think about bosutinib if it's available, because it doesn't seem to have the cardiovascular toxicity of the other second generation drugs. So that was something worth considering. Also, the dasatinib dose, I think it was right to come in with dasatinib. I think as soon as you know that the response is good, which you did in this patient, it'd be reasonable to consider a lowering of the dose, which I think you did as well, because of the ongoing challenge of cytopenia. So in terms of the how do you approach these patients with cytopenia, we tend to be aggressive in the first few months, so we won't necessarily stop dose unless the platelet count is, say, 20 or below. We'll always use G-CSF to support neutropenia. But once you see a response, we back off quite dramatically. So luckily, this patient at 3 months was down to something like 0.5%. So you knew the patient was responsive. At that point, you don't have to be quite so aggressive. You can be a bit more cautious. But until you know whether the disease is responsive, I think you need to err on the side of being somewhat aggressive in the presence of cytopenia.
Yeah, I second that.
Yeah, great case, Anna. My only just remark, because you already said everything, is about the bone marrow. I think the bone marrow has been forgotten in chronic myeloid leukemia, and it's a good point to remember. We have to check the bone marrow. I just wanted to say that because we see a lot of patients that are not ever having a bone marrow biopsy. And we have to remember that these people can have other things that we, myelodysplasia, or even be in a blastic phase, and we don't see it. So it's always because this is a patient's high risk, and usually the patients that go with cytopenias are the worst ones. It has been associated with worse prognosis also. So I think the bone marrow it's a good point to make.
And
If I can
Inés,
just
any thoughts before we go back to Mike?
No, I agree with what was said by Virginia. Actually, I agree with all three of you, but I agree with Virginia about the fact that when the disease is diagnosed, we oftentimes decide that myelogram and a phenotype is enough to move on, but we overlook the need for a bone marrow biopsy, which will provide us with more information. And that's something that I believe needs to be considered with all patients who are very anemic or with some sort of cytopenia. And we have to do more BMBs.
Yeah, and I wanted to emphasize in this because I see a lot of patients diagnosed only with a PCR. And I think that's a really big mistake. We see each time more and more, and I think it's important to address that point.
Mike.
Yes. There was another hidden an Easter egg, as they say. Unfortunately for this patient, he did have fibrosis in the marrow as well, had 1+ fibrosis, which could impact myelosuppression risk. And making us all current, the World Health Organization has really highlighted that CML may be more of a biphasic than a triphasic disease. And for example, a diagnosis of bone marrow, it helps you understand if there's any high-risk features, such as a small population of B lymphoblasts, which could lead to transformation without warning. In my clinic in the US, you might think we're a little bit more, relaxed or, not at all. I suggest and sort of implore patients to have a marrow, and I would do exactly as Dr. Prado had advised. If you have myelosuppression that's unexpected or prolonged and you don't know what the response is, you need to do a follow-up marrow.
Thank you. There are no questions up on the chat yet, so we might move on to case 2. But if you have questions, we might try and come back to them again once Ana Inés has presented her second case. So for now, we'll move on. But any thoughts on this case after Ana Inés's second presentation? Please just put them up in the chat function or raise your virtual hand. Ana Inés, thank you very much. Your second case.
My second case is a 61-year-old male patient who was referred to us from another center. He has chronic gastritis and GERD, which is not currently or at the time of consultation under treatment. He also has spinal osteoarthritis, chronic. He was diagnosed with chronic phase CML, with a low-risk SoCal, and Utah's also low-risk 2 years earlier at 59. He was put on imatinib 400 milligrams once daily for a month, but the treatment was discontinued due to vomiting, and his reflux had worsened. So the colleague who was in charge of the case switched him to hydroxyurea, and he was kept on hydroxyurea for 2 years. He went to a general practitioner at 61 years old for back pain, and he was examined, and his CBC was with a WBC of 150,000, myelemia, moderate anemia, and his platelets were normal. So he called us and referred the patient to us. When the patient came in, we once again did assess his disease to see what the status was at the time. So his BMP was that he had 4% blasts. Cytogenetically, his Phi was 100% with no associated abnormalities. BCR-ABL, he had the classic isoform at 74%, and abdominal ultrasound showed an enlarged spleen at 19 centimeters. He also underwent gastroscopy. He had moderate esophagitis, non-atrophic chronic gastritis, and he was negative for Helicobacter pylori. As we immediately reached out to the patient, and we started a dietary and hygienic treatment. He was put on omeprazole 40 milligrams daily and domperidone 20 milligrams daily. And this was all done while he was being reassessed for his CML. So this all began a week before imatinib. We stopped hydroxyurea, and we put him on imatinib 400 milligrams once daily with his main meal. It was well tolerated with minimal nausea, and he had clinical improvement of his GERD. He kept being followed up on, and he achieved therapeutic goals. At 3 months, his qPCR was 6.5%, and he attained complete cytogenetic and major molecular response at 6 months. Whenever a patient comes in, we pay a great deal of attention to all comorbidities to make sure that CML treatment with a TKI, whatever we have, that we need to start them on, and the rest of the other treatments for the other comorbidities can coexist in harmony, and the patient can stay on treatment for all of their morbidities. So we have to make sure that we pay attention to drug-drug interactions, and there are guidelines which are readily available at our hospitals, and imatinib and omeprazole do not interact. Imatinib plus domperidone do create an interaction, and there may be an increase in domperidone levels in the blood, and that may lead to a risk of QT prolongation and cardiac arrhythmias. That's why he was monitored to see whether there were any such issues, and he also had an electrocardiogram. And when dasatinib is available, and if the patient needs to be on omeprazole, you have to bear in mind that there is a major drug-drug interaction there, and that the guidelines suggest the use of a different type of medication, because omeprazole may decrease the therapeutic effect of dasatinib by increasing gastric pH. When we looked at nilotinib plus omeprazole, there's also the idea is not to use this combination, because nilotinib loses solubility with higher gastric pH, and it's not enough to just space out the times of the medication because of the effects of the proton bomb inhibitor. We felt it would be interesting to talk to Dr. Mauro about the new formulation of nilotinib, nilotinib tartrate. And it's a different nilotinib that has been approved for CML, as opposed to Tasigna. It does not require fasting, because it can be taken with food. And the efficacy is equivalent to that of Tasigna. And what we need to bear in mind is that the doses are different. For first line, 142 milligrams every 12 hours. And for second line, 190 milligrams twice daily. So Tasigna is a different formulation, and that's why the dosing is different as well. We're used to receiving patients who are usually between 50 and 60 years old, sometimes older, with comorbidities usually. So we have to find a way to strike a balance for them. And so our questions were, in addition to the comorbidities reported by the patients, so in this case, GERD, we wonder whether in clinical practice you also analyze the comorbidities that arise from the clinical history of the patients, or if you do some other type of workup to see whether there are other conditions that may lead to greater complications with treatment. Also, another question is whether you perform routine monitoring for hepatic and pancreatic toxicities that we've heard about, and whether you look for possible electrolyte imbalances, and whether you do electrocardiographic abnormalities as a matter of course. And then for patients on dasatinib, do you usually do a periodic screening for all patients to see whether there's pleural effusion or pulmonary hypertension, or whether that's performed only for patients with a pre-existing cardiac or respiratory condition?
Thank you very much, Ana Inés. Another great case. We might start off with Mike again, please. Your thoughts.
Or yeah, so the first thing I'd like to say is thank goodness that this patient made it to Dr. Prado's clinic after all that time without therapy on hydroxyurea, because this sounds like it was a simple case of lack of information about the dosing of the drug and how to avoid some of what can be severe gastrointestinal toxicities. You know, early days of imatinib, taken on an empty stomach or not taken properly, imatinib can cause severe GI issues. So, and it also raises a very important issue regarding management of this common comorbidity of reflux GERD. I'm in New York, and I live in a world where proton pump inhibitors are sort of given out like candy, unfortunately. So many patients are on them and take them indefinitely. And it really highlights the simple diligence of a clinician to take a good history, inventory of drugs, comorbidities, and concomitant medications, because missing that could essentially lead to severe reductions in, for example, dasatinib exposure, more than 50% reduction in exposure if a patient takes omeprazole with dasatinib. there are other ways to manage those issues, even with using the conventional forms of the drug. There are newer formulations of dasatinib and nilotinib. Nilotinib, this recent approval of this other compound, which is maybe addressing another issue, which is the adherence and compliance with taking a twice daily drug that requires fasting, which nilotinib does require. When chosen correctly for the right patient, nilotinib is very good, but it's only good if it's able to be taken out properly, and that fasting, losing the fasting requirement can make a big difference. But again, the simple inventory and looking at someone's health history. But what do the questions that are posed for me and were more, what more do we do? And I think there isn't a slate of tests that I think are required. It's actually quite simple. It is really just taking the history and understanding. And for example, as someone with known cardiac disease or cardiac events, there might be more to do. One of the most simple things that can be impacted by TKI therapy, particularly with either novel agents like asciminib or ponatinib or many drugs, would be blood pressure monitoring, and that's simple and it's probably the easiest thing to identify and treat. By just understanding the patient's history, you'll understand whether they might require some either avoidance or increased monitoring, for example, of fluid status, blood pressure, or vascular disease monitoring for that matter. But doing it in all patients may not be necessary, but in many patients it's helpful. I tend to look for cardiovascular studies in patients who are about to start or need to start high-risk medications like ponatinib, if it's still used in such a patient, or nilotinib. We learned a lot from our most recent studies with regards to the spectrum of toxicities we see with first-line therapy. And I have done for years pancreatic monitoring in all patients, which may not have been necessary, but I think the Ask for First study, which was a comparison between asciminib and all of the common frontline TKIs, showed us that pancreas toxicity is probably more of a general effect we see with all TKIs. It may be somewhat greater with certain drugs than others, but it's often not associated with pancreatitis. It's maybe just a metabolic or a hyperlipemia, but it's certainly worth knowing about. And by being a little bit more meticulous with low cost and easily accessible tests, we can avoid problems. EKG monitoring is, in the select patient in whom a new drug's added with a QT prolonging effect, like Dr. Prado mentioned, or a drug with effects like nilotinib. I think or a patient who has prior issues with rhythm, issues of the heart, something dear to me. And then dasatinib and its intrinsic toxicities that are inflammatory, that cause fluid retention. I think the history, again, is the most important element, and not at presentation, but with time. If someone has symptoms of pleural effusion, they're quite easily ascertainable, and that can trigger an X-ray, because it's actually unlikely to necessitate in most patients treatment cessation. It may require a drug hold or a dose reduction or even intervention, but it often can be managed. Pulmonary hypertension is a bit more sneaky. I would hope we would have some sense for symptoms well before it would be clinically evident. There are recommendations that echocardiograms can be performed in dasatinib patients, but that may be challenging to apply broadly. I think, I might have the luxury of doing that in my clinic, but I don't. I think it can be taken on a case-by-case basis. So these are great points, and it really just highlights that by being pragmatic and taking a good inventory and a good history, and then doing key things with monitoring, we can both save the patient from poor response or toxicities. We can optimize the therapy. We can choose therapy better, maybe, and really do well.
Thank you, Mike. We might go to Virginia first for her thoughts, and then Tim, and then perhaps Ana Inés, and then open up to some questions from the audience. I can see one already there from Lillian. Thank you. So Virginia first, please.
No, well, I think it's a very interesting case, as Tim said, and Michael said. So maybe a lot of times we see patients that fall out of treatment just because they were not treated with the comorbidities. Regarding your first question, I don't do much workup before the treatment. I just do the cardiovascular. That's something that I do. We do vary throughout. We establish the risk, the cardiovascular risk, and depending on that, we send them to the cardio-oncologist, which I think it's very good to have if we're going to treat CML or CLL. And so we do that. We do echocardiogram and do establish the risk. And then the other thing is just examining the patient and seeing what's going on with the patient. I think the most of the patients, if you have a good history before starting, it's all right. And then we don't do X-rays or anything else to look for toxicities again, unless we have clinic.
Yeah, I don't have much to add to that. I mean, we don't do ongoing routine chest X-rays either, because in virtually every case of significant effusion, a patient will, and if not volunteer, we'll tell you when you ask specifically that they've had recent increase in shortness of breath, and you can easily then prove that that's a pleural effusion. I think, yeah, pulmonary hypertension is more worrying because it's rare, but it's a nasty complication. So if we suspect that the respiratory symptoms are not explained by pleural effusion, particularly in females, we will go to a cardiac echo to see if there's any evidence of pulmonary hypertension, because that is something we want to absolutely avoid. In the probably five or so years ago, when I tended to want to use nilotinib for my middle-aged patients who I was being ambitious about achieving treatment-free remission, I would do some fairly careful cardiac pre-screening, even sending them to a cardiologist because of the known risk with nilotinib. But following the Japanese study that demonstrates that a dasatinib gives you virtually identical molecular responses to nilotinib, I tend to prefer dasatinib in most patients now. I'd rarely use nilotinib up front, and I feel less nervous about dasatinib because we generally use it at the modified dose of either 70 or 50 milligrams daily for nearly all patients, so that I think the cardiac risk here is a lot lower. And so it's not necessary in those cases. We always do an ECG at the start, just in case there's an unexpected issue that needs to be further investigated. But yeah, what other questions are there? That's yeah, I think I agree with Mike that the pancreatic toxicity we were very worried about with asciminib when we first started using it. It does appear to be almost exactly the same for all the drugs, and certainly in most cases just a lipase elevation without actual pancreatitis. So we don't worry about that too much.
Thank you. Some very comprehensive responses there. We might go to a question on the chat from Lillian from Chile. Do you recommend hospitalization when a patient with CML presents with hyperleukocytosis to start the TKI and start measures to prevent tumor lysis syndrome, or is it safe to treat on an outpatient basis? Mike, what are your thoughts?
Well, I would certainly want to be a bit more cautious in someone that was actually having a direct complication of hyperleukocytosis, such as respiratory symptoms or vascular symptoms or priapism or something along those lines. Simple hyperleukocytosis, I think, can be managed with hydration, allopurinol, or medicine to reduce the uric acid level and careful monitoring. If we're able to see those patients ahead of time, they may require, those are the patients that may benefit from some cytoreduction. But I think with careful monitoring and instructions, most patients can be managed outpatient.
Tim?
Yeah, generally the same as that. We probably have maybe a lower threshold to bring a patient in for a couple of days, just to make sure they are adequately hydrated as we start them on the hydroxyurea, to make it easier to get a daily count, because it's sometimes difficult to titrate the dose of hydrea. Also gives us a chance to get to know the patient, give them plenty of information in a more kind of relaxed, if you call it relaxed to be in hospital, but it's probably, it can be quite a useful way to introduce yourself to the patient and get them fully understanding the situation that they're in. So I don't have a problem with a patient whose white cell count is over 100, bringing them in for a day or two to stabilize things, but it's probably only actually essential when they have some symptoms.
Virginia?
No, I think most of patients you can manage ambulatory, unless you have really symptoms or whatever. Most of them we can manage them. I have never seen, actually, I have never seen a tumor lysis syndrome in a CML, except for patients in blast crisis. I saw one, and it was very painful because he had a lysis, and then nobody, saw it, and end up with renal failure. But it was the only time I saw that.
Ana Inés, do you have some closing thoughts on the responses you've heard from our experts, other experts?
I really appreciate all those comments, which were very good. Oftentimes, especially younger hematologists or younger practitioners, get distracted on paraclinics, and they forget that they have to actually ask questions, do a physical exam, have a good relationship and a good dialogue with the patient. And that's where you get very valuable information that you can then use when time comes to treat the patient and follow up on treatment and monitor the patient. So I think you have to, everything is important. The clinical part is very important. Of course, we'll refer to studies, but everything in its right place. So thank you very much, everyone.
Thank you very much, Ana Inés. If I could ask you to take your slides down, please. Just while I'm getting mine back up to introduce our next speakers. Mike, do you want to close off that discussion?
I don't really have much more to add. I think those are beautiful closing comments. And Tim's comment about getting to know the patient and giving them information, that's so important. Information's power here. You can't spend enough time with someone as they're diagnosed with CML to let them know what to look for and what you're doing and so on. So it's so important. And I feel bad for the patients that come after my newly diagnosed CML patients in my clinic because they're waiting because I'm talking to the newly diagnosed patient for way too long.
Thank you very much. And yes, unfortunately, this always happens. We've run out of time for this topic. Thank you so much, Dr. Ana Inés Prado and Professor Mike Mauro for leading a great discussion there. Of course, our other experts. I can see there was one more question that came up in Spanish. We might try and get back to that afterwards. I'll ask someone to hop in and translate that for us. Any unanswered questions, perhaps apart from that one, don't hesitate to get back to me and I will get you a response.